Luna Gargani will highlight the usefulness of echocardiography in critically ill patients through a series of illustrative cases. She will also focus on what to look for using a step-by-step approach that focuses on the main clinical condition.
In critically ill patients, the echocardiographic approach can be different according to patient's condition. So the examination should be focused on the main clinical suspicions. If you have a critical but stable patient, such as a patient with acute dyspnea, echocardiography can be very useful to detect a cardiac etiology of the symptoms, and in that case, to establish what is the main cardiac abnormality. So first thing to do is to look at left ventricular function. So you should start with the parasternal long axis view, like this, and check for left ventricular function. You should see whether LV function is grossly impaired. Then you should try to establish the degree of LV impairment. Although if you have a very symptomatic patient, whatever is the cause, it is likely that that abnormality is severe. Then you can quickly turn into short axis view, like this, to confirm your impression. From the short axis view, you can also assess whether you have a D shape of the left ventricle, such as in significant right ventricular pressure overload, for example, in a case of acute pulmonary embolism. Now you go back to the long axis view, and in a patient with left ventricular dysfunction, it is important to assess whether you have a global LV dysfunction or if you have some regional wall motion abnormalities that can suggest a current or previous coronary syndrome. It can be useful to take some measurements. It depends on how much time you have and how feel the patient, but at least try to take left ventricular and diastolic diameter and interventricular septum thickness. From the parasternal long axis view, you should also give a look to valves. So you should assess aortic cusps and mitral leaflets, calcifications and opening. First of all, you have to get this impression, morphological impression, to understand whether that can be a reason for a valvular heart disease and eventually establish the mechanism. Then you have to evaluate color Doppler, and in case you have doubts, especially in moderate regurgitation, you can quickly measure the vena contracta. Of course, check also the mitral valve. That can be a very common cause for acute symptoms. Then you should turn to short axis view, like this. And again, it's very important to assess aortic valve morphology and opening, because acute or chronic aortic stenosis can be a very common cause of acute symptoms in critically ill patients. And if you see calcification of the valve, but you can appreciate a good opening, aortic stenosis is not going to be the problem, the acute problem of this patient. Now you should go to the apical four-chamber view, where you can better appreciate left ventricular function. And again, it is important to establish whether you have a global dysfunction or if you have regional wall motion abnormalities. It's also important to check on the two-chamber view, again, to assess whether you have some left ventricular wall motion abnormalities. Then, from apical four-chamber view, you can reassess both mitral and aortic valve. The possibility to use more quantitative parameters of assessing valves, such as, for instance, the PISA method for mitral regurgitation, depends on how much stable is your patient and how much time you have, and also on patient's conditions, because it is likely that your patient, if he is significantly ill and very symptomatic, cannot easily take the left decubitus. So, in critically ill patients, it's also important to have a non-invasive estimation of stroke volume, and you can get it by assessing LVOT, the left ventricular outflow tract diameter, and the time velocity integral by pulsed wave Doppler, like this. And this is important because you can assess changes in stroke volume. And since the LVOT diameter is not going to significantly change in the same patient in a short time frame, you can easily just check the changes in time velocity integral values. And this can be very useful also to assess fluid responsiveness. You always have to check also to left atrium. That is a very important parameter. First of all, you get an eyeballing impression whether the left atrium is dilated, and this can be better defined by assessing left atrial volume. Then it's important to give a look to diastolic function. So first by E/A ratio assessment. Then, if it is available on the machine and if you have enough time, by tissue Doppler imaging, you can assess the E/E' ratio. This is very important because a patient with a normal systolic left ventricular function can have acute dyspnea because of a significant diastolic dysfunction. Then, you have to look at the right heart, which is very important in critically ill patients. And you can perform some more focused view of the right heart to assess whether the right ventricle is dilated and or dysfunctional, such as in massive acute pulmonary embolism, or to see whether you have a paradoxical motion of the interventricular septum. A quick way to assess right ventricular function in a critical patient is by M-mode evaluation of TAPSE, like this. This is rather simple but very useful. And of course, it's very important to assess pulmonary artery systolic pressure by continuous wave Doppler on the maximal velocity of the tricuspid regurgitation. Then you should have your patient in the supine position and scan from the subcostal view, like this, and check for pericardial effusion. Then you should search for the inferior vena cava, and it's important to assess both the diameter and the collapsibility during respiration. So you may have a normal pattern like this, and you can use the M mode to better assess the collapsibility during respiration. Or you may find a very dilated and without any collapsibility inferior vena cava. And this is very important also for fluid management in critically ill patients. In case you cannot easily find the inferior vena cava, and if your patient is compliant and can do that, you can ask the patient to lift the legs like this, and then you can more easily scan the subcostal view like this. You can also get very important information from ultrasound of the lungs, and you can use the same cardiac probe and keep the same cardiac setting you've been using during your echocardiogram. So you just have to move your probe from the heart to the lungs, and you can scan the lung anywhere along intercostal spaces like this. So you have to avoid the ribs and put the probe longitudinally in the intercostal spaces. What you see in a normal aerated lung, so in a lung without, for example, pulmonary congestion, what you see is this horizontal hyperechoic line, and as you can see, it's moving synchronously with respiration. This is the image of the pleural line, and you don't see anything else if you have a patient with an aerated lung. Whereas, if your patient has extravascular lung water, what you see are these hyperechoic reverberation artifacts, vertical artifacts, arising from the pleural line and again moving with respiration. These are called B lines, and they are the sonographic sign of the pulmonary interstitial syndrome. And if you have a patient with acute dyspnea and you don't find multiple bilateral B lines like this, this has a negative predictive value close to 100% to exclude a cardiogenic pulmonary edema of your acutely dyspnoic patient. If you have an unstable patient, such as a patient in shock or with severe hypotension, you can use specific, more focused protocols, such as the FATE protocol, that can help you to quickly establish serious life-threatening conditions. So you will use a convex probe, but you can also use your cardiac probe. So it's not a problem of your probe. You don't have time, you just get the probe you have very easily at hand. And the FATE protocol consists in scanning the subcostal view, like this, and then quickly moving to the apical four-chamber view. And your patient, of course, is in shock, so the patient will be supine. And then moving to the parasternal view. And then you have to scan the right costophrenic angle, like here, and you will see the liver, and you will see the lung coming on the liver during inspiration. And here you can search for pleural effusion. And then you scan the left costophrenic angle exactly in the same way as you did on the right side. And you see the same picture, but with the spleen here instead of the liver. And you see the diaphragm, this is the diaphragm, and the lung coming over the spleen during inspiration. If you don't see pleural effusion here, you don't have a free pleural effusion for sure in this patient. If your patient is in cardiac arrest, the FEEL protocol can be integrated directly into advanced life support by quickly scanning the parasternal long axis view, like this, and then the parasternal short axis view, like this, then moving to the apical four-chamber view, like this, and to the subcostal view. And this protocol can help you to detect some of the treatable causes of cardiac arrest, such as cardiac tamponade, as in this case, or massive pulmonary embolism, or severe left ventricular dysfunction, or hypovolemia. If you have a patient with trauma, the FAST protocol is indicated, and you should scan the right upper quadrant, the upper abdominal quadrant, like this. And you can see this image it's the perihepatic space, and you see the liver here and the kidney here. This is useful to exclude that you have a hemoperitoneum in your patient. And you should do the same exactly on the left side. So you scan the left upper abdominal quadrant, like here, and you have the same picture, but now with the spleen and the left kidney. Then you should move to the pelvic position, both longitudinal like this and transversal like this. This is the Douglas patch, and again it's useful to exclude that you don't have some free fluids in your abdomen. And then you go to the subcostal view again, in this way. So you may diagnose or exclude both a hemopericardium or a hemoperitoneum. There is also an extended version of the FAST protocol, which is the E-FAST. And in the E-FAST, you also scan, again, the right costophrenic angle, like this, and the left costophrenic angle, like this, as we have seen before. And very important, you can also scan your chest to diagnose or exclude the presence of the pneumothorax. So you have to put your probe longitudinally within the intercostal spaces like this on the upper part of your thorax. And if your patient doesn't have a pneumothorax, what you see, as we have seen before, is this image of the pleural line, which is moving synchronously with respiration. If you look here, you see this line moving compared to all the rest of the picture. If you have a patient with pneumothorax in the same position, you will see this line completely still, so no movement of the pleural line. So we have seen an overall examination of both a critical but stable patient and on an unstable patient. It's very important that you keep in mind to have a step-by-step approach that should be focused on your main clinical suspicions. So critically ill patients are very different from stable patients that we see every day in our clinical practice, and so also the echocardiographic approach should be a little different in these very sick patients.
So what are the most common questions that you should be able to answer using echo in critically ill patients? First, what is the left or the right ventricle functions? Is there any valve lesion? What is the fluid status? Is there any pericardial effusion compromising the hemodynamic status?